Local anesthesia, LA, or numbing is a treatment that provides reversible loss of sensation and eliminates pain perception within a local area. The goal is to create a local reversible anesthesia and analgesia so that the patient feels neither pain nor sensation during the procedure, but function returns afterward. The main nerve responsible for sensation in all teeth and surrounding tissues is the trigeminal nerve, NV. This nerve divides into three branches: V1, N, V1, ophthalmicus, V2, N, maxillaris, and V3, N, mandibularis. Two main techniques are used to anesthetize the teeth: infiltration anesthesia and nerve block anesthesia. I, maxilla, upper jaw. The upper jaw is innervated sensorially by N. maxillaris, V2. 1. Choice of technique. In the upper jaw, the bony lamella covering the roots of the teeth is thinner and less compact. This enables the use of infiltration anesthesia. Through infiltration, the plexus alveolaris superior, a nerve plexus that innervates the upper teeth, is blocked. Each tooth can be anesthetized individually. 2. Anesthesia on the buccal vestibular side, teeth. The anesthetic solution is injected as a depot locally at the apex of the tooth to be anesthetized. The needle tip should be placed as close to the apex as possible. Incisors. The needle is inserted angled toward the apex while the mucosa is kept taut. Canines. The needle is inserted parallel to the tooth in the canine region where there is ample space. Premolars. Infiltration is done buccally, apically, usually 1.0 to 1.8 milliliters of solution. Molars. In the molar region, the zygomatic bone, zygomaticus, may interfere. Therefore, the lip and taut mucosa are pulled outward, downward to create space. 3. Anesthesia of the palatal side. A supplementary injection in the palate is necessary for pain-free procedures such as extractions, gingivectomies, or scaling. The palate has attached gingiva, which is difficult to inject into, providing more resistance and greater pain. The patient should be warned. N. palatinus major. Inject at a right angle to the mucosa, at approximately half the root length, near the foramen palatinum majus, located at the level of the first molar apex, where attached gingiva transitions to movable mucosa. N. palatinus major innervates the hard palate and the palatal mucosa. N. nasopalatinus, blocked at the border of the incisive papilla with the syringe directed from the lateral side. This nerve innervates the anterior hard palate. 2. Mandible, lower jaw. The lower jaw is innervated sensorially by N. mandibularis, V3. 1. Choice of technique. In the premolar and molar areas of the mandible, the bony lamella covering the roots is thick and compact. Therefore, nerve block anesthesia is the primary technique in the posterior mandible. 2. Anesthesia of molars and premolars, block. Nervus alveolaris inferior, N-alv-inf. This nerve, which innervates the mandibular molars, is blocked using a mandibular injection. The injection is administered just before the nerve enters the foramen mandibuli. This technique anesthetizes several teeth on that side. Injection site. The needle insertion is made about 1 centimeter above and parallel to the occlusal plane. The direction should be from the premolar canine region of the opposite side. The insertion is slightly lateral to the plica pterygo-mandibularis. Nervus lingualis, N. lingualis. Because N. lingualis, which innervates the tongue, gingiva, and mucosa in the mandible, lies close to N. alv-inf, it is anesthetized in 9 out of 10 cases during mandibular injections. This can lead to tongue numbness and temporary taste loss. N. lingualis can be blocked with 0.4 milliliters of solution by withdrawing the needle approximately 0.5 centimeters from the foramen mandibuli. Verification. When N. alv-inf is anesthetized, parts of the chin and lip also become numb, because N. alv-inf becomes N. mentalis as it exits the foramen mentale. One way to check if the anesthesia has taken effect is to touch the lip. 3. Anesthesia of incisors and canines. In the anterior region of the mandible, incisors and canines, the bony lamella is thinner, and infiltration anesthesia can be used. Inject about 0.5 milliliters and be careful with blood vessels. Note that the lower anterior region has double innervation. 3rd, general advice for injections. Regardless of which tooth or jaw is anesthetized, the operator should act calmly and reassuringly, inject slowly, perform aspiration to avoid intravascular injection, avoid injecting directly into foramina, place the anesthetic depot as close to the nerve as possible. Local anesthesia is often combined with vasoconstrictors such as adrenaline or octapressin, which reduce the washout of the anesthetic, decreasing latency, onset time, and increasing duration.